Okay, welcome to Family Medicine Grand Rounds. For everyone who's joined us in person, also for those of you who are virtual, joining us through Microsoft Teams. I would like to also thank FMIG for providing lunch today. Thanks for organizing, Dr. Ford, who's not here yet, and the FMIG leaders. Before I introduce our speaker today, I wanted to let everyone know our lecture is from noon to 1, and then from 1 to 2 p.m. we have some time for meeting and greeting with Dr. Bazemore here. For those of you who are virtual, feel free to use the chat to put in your questions or comments. I'll be monitoring the chat. And also when we go into the question and answer portion of the presentation, feel free to unmute yourself to speak as well. With that, I would like to introduce our special guest today, Dr. Andrew Basmar. He is a Senior Vice President of Research and Policy for the American Board of Family Medicine, where he oversees the research enterprise, co-directs the Center for Professionalism and Value in Healthcare, and he coordinates and develops the ABFM career development activities. He was previously the director of the Robert Graham Center for Policy Studies in Family Medicine. He has a special interest in access to care for underserved populations, health force training, as well as measurement science and geospatial analytic applications for primary health care. Dr. Bazemore, when he was at the Robert Graham Center, developed tools to empower primary care providers, leaders, and policymakers, and co-developed Health Landscape, which is an innovative data engagement platform, particularly the Uniform Data System Mapper, which is a contract that guides funding for all the nation's federally qualified health centers. He has also served in national policy roles, and particularly he was elected to the National Academy of Medicine in 2016, and he leads the primary care interest group. Dr. Bazemore is also a faculty at the Department of Family Medicine at Georgetown University and the Virginia Commonwealth University, and he provides patient care at the VCU Fairfax Family Medicine Residency Program. Please welcome Dr. Andrew Basmar.
Thank you, Dr. Gassa. Let's see if I got this right. Am I coming through on the mic? Everybody hear me? Great. And I'm told that this is what I'm supposed to do, but if anyone's uncomfortable, if I start violently coughing, I promise I'll put the mask right back on. And I'm a little blinded. I'm a bit of a wanderer, but I understand as long as I stay in this space, folks in the virtual world can still see and hear me. But I'll count on Dr. Gassa to tell me if I've violated my virtual stewardship here. So yes, I'm thrilled to be here, and I always like to start with a little knowledge of who I'm having a conversation with. I know that there's a pretty large family medicine interest group contingent here today, so if you don't mind, just by a quick show of hands, who are the students in the room? Awesome. And faculty? Okay. And among the students, what years? How about second year? See twos. All right, a little bit of a mix, but a lot of twos. That makes sense. That seems like about the time that you can be in a space like this. I'm gonna ask the twos, what are you doing? What were you doing this morning? What are you doing this afternoon? Class? So okay, excellent. A whole lot of class. Sounds good. A little bit, to be fair, about me. I'm a family physician, as mentioned. Actually born in a now closed Tachikawa Air Force Base in Japan back in 1971, about a year before I believe USU was birthed. Have tremendous appreciation for and have worked with a considerable number of grads, not only of this program, but the GME side of military medicine, and am profoundly impressed by its impact on generalism and on generalism leadership. I was saying earlier to Dr. Gassa, I can't really sit in a boardroom, particularly in family medicine generalist spaces, and not look left, right, or center and see someone who's come through military training. It has a huge impact beyond the clinical care and delivery, and we'll touch on that a little bit today. This title And the word high performing are not accidental. I won't claim that we have a high performing primary care delivery system. Won't claim we have a high performing delivery system. We'll touch on that in a moment as well. I think if we're going to get there, there are a lot of things that we still need to achieve. But I'll also tell you, if I were a student and going back through my training pathway again, I still would pick a generalist pathway. It is, you know, and that certainly reflects some of my biases and personality, but also I think the opportunities that I see ahead for a better functioning and a higher performing health system. We'll touch on a new National Academies report, the first in 25 years, that is specifically named implementing high performing primary, or high quality, they say, but it is all about high performing primary care. And how we might get there is something that I won't have the time to cover today, but if you haven't seen the report, it was very specifically an implementation report. We'll talk about definitions today a bit, but this one was about how do we get there. Let's see how we do in advancing. I was at the Robert Graham Center, as mentioned, a policy studies center that is just down the road. Highly encourage any students interested and with time, take a clerkship month, go hang out with the Graham Center folks, or come hang out with us. We do a lot of secondary data work, also some qualitative work, trying to understand things like how you achieve high-performing primary care, how you implement better policy. I also I manage a team in Lexington. That's where the Board of Family Medicine is based. I also help to manage a team here in DC, the Center for Professionalism and Value in Healthcare. It has a tagline at the top of the website that kind of summarizes what we do. We're professionals. We take oaths. Professionalism necessarily involves a contract, not only with patients, but with society. And we're granted an awful lot of rights and privileges that most other employment opportunities that don't have that professionalism contract aren't. And we're increasingly finding ourselves in systems and payment models that challenge some of the things that we take an oath to preserve about first stewarding and caring for the needs of patients, not harming them, of course. And again, in a value-based payment world, it's not necessarily lined up with our professional values. So we're a center that's about trying to make sure that we retain the values of the profession and what we value with payment and delivery system models. You know, I think if you bothered, I don't always read them, to look at abstract and learning objectives, you get the basic idea. I certainly hope we can explain when we're leaving together what high-performing primary care can look like, talk a bit about the barriers and obstacles to getting there, and then get a little specific. What does this mean for USUS and a military medical system? And if I'm good and I'm fast enough, that part's more discussion because I don't have all those answers. I can certainly reflect on what I know about the military medical system and USUS, but I think I'll count on you to tell me more and hopefully through some questions help us understand there and how it relates to health system needs. Anybody know who Abraham Flexner was? Okay, a few folks in the room. What do you know? Sure. Carnegie Foundation, wow, that's a lot. That's impressive. So Carnegie Foundation funded. Some think there may have been some other subtle interests. Most reports that go federal have those. And absolutely, it looked at a system of health education training by comparison to European and much older peers and said, we have lost our standards in our way. You can turn out a snake oil salesman or a really highly qualified doctor from the same training environment, well, not necessarily school, but general environment. And without standards, we won't be able to tell the American public what this professional is and can do. The good news is what you said. About 1910, it really did turn our attention to standards of education. Really helped to elevate kind of the trust, and that's something, you know, in 2021 that resonates pretty highly, trust in professional. But any report, and anytime you close 60% of American medical schools, you also have some unintended, possibly predictable consequences. And Abe himself said, you know what, science, and he would say his was an educational science, and the very act of solving problems creates more of them. What problems do you think Abe Flexner's report created in closing about 60% of existing med schools? Access. You can imagine in particular what kind of schools which might have had a really important role in caring for vulnerable populations were closed. You lost 5 of your 7 historically black medical colleges courtesy of this report. And that was actually, interestingly, in a time when we go back and say, boy, there was a really profound undercurrent of racism in the person. Abe Flexner actually said that's not what he intended or wanted, but nonetheless, that was a consequence of the report. On top of that, he closed a lot of programs in middle America and in rural America, and a lot of programs that served those. USUS is 60 years in its foundations after this report, not directly affected. But a thing I will note is, boy, your campus is amazing. Just gorgeous. I've not had a chance to be here before. And it's big. And I saw that model out in the hall of what's coming. Flexner also created a huge consolidation of resources. And with consolidation in industry, you can say, well, there's efficiency. There's also a lot lost. Not a lot of training was left in communities, by the community, for the community. And you just had to have faith that consolidation was going to trickle down and serve those. He also created an industry of training. And boy, if you've been to Johns Hopkins, Harvard, Texas, MD Anderson Medical Center lately, you know what I mean. Massive training enterprises meant massive hospitals and really a huge economic agent. And one of the things that you might say was lost was a sense of ecology. And for the scientists in the room, I know you're going to be thinking about birds, frogs, and animals when I speak of the word ecology, but it has a place in healthcare too. And Carr White, one of the founding fathers, really a forefather of generalism, public health, and health services research, amazingly, at my alma mater at Chapel Hill back in 1961, was working out the ecology of healthcare. And he said, you can create these boxes to represent where the population with the symptoms they have actually receive their care, their delivery system model. At the Graham Center, we, 40 years later, published a follow-up to his work and said, in an average month, you can estimate that you're going to have about 1,000 people with 80% of whom are going to have some kind of a symptom. That doesn't mean they seek care, but they have symptoms. Within that cohort, or that box, you have another 327, so about a third, who end up considering seeking medical care. And we were using a number of large data sources, mostly survey-based, nationally representative surveys at this time. 217 land in a physician's office, 113, so half land in primary care. 65 visit a complementary and alternative medicine provider. One can imagine we had limited data there. It could be much larger or smaller depending on how you define that now, but roughly 65 and 1,000. And that includes a lot of different categories. 21 in a hospital clinic, 14 in home health, 13 in the emergency room, 8 in the hospital. And guess what the small box is? That is where you do all of your training, academic health centers. So the other consequence of consolidation in medical education is that your hospital training environment is not reflective of the ecology necessarily, unless you go out of your way to make sure that's retained. You can imagine the consequences. I'm sure that the phrase hasn't changed since I was in med school. When you hear hoofbeats, first think horses, not zebras. Academic health center hospitals tend to consolidate the bizarre, the complex. That has some real advantages, but also leads to a different culture of resource stewardship. I know that the military medical system is different in positive ways. On top of that, one of the consequences of Flexner and these massive systems were creating what some would call a wealth care system, a US environment that is driven less by the needs of the end consumer and more by the economic dimensions of care itself and of those who provide it. And we see that in a lot of different ways. Again, we could spend an hour on that, but I'll try to keep it short. Your national health expenditures are pushing 20% of gross domestic product. It does have trickle-down effects on our competitiveness in many, many industries and on our workforce and on our environment. We are an outlier. I could show these slides for hours. This is a pretty simple one. It only goes to 2004. You can imagine that continues to diverge. That just says year by year by year, we continue to outspend. This is adjusted for purchasing power parity, all of our industrialized peers, and yet our performance, as you hear over and over again, this is one of a dozen of these scales, lags those same peers when you add it up, whether it's, again, in quality, access, efficiency, equity, healthy lives, or expenditures. The only place we tend to score very highly in health system comparisons, labeled a lot of different things, but they would say one form of availability. If you need an MRI and you have the money to pay for it, you're in a great system for accessing that MRI or a subspecialized form of care. However, if you don't tend to do quite as well. And it leaves America as consistently the outlier in any equity scale. This is a simple national question. All right, percent of patients who didn't get the recommended test, treatment, or follow-up because of cost in the last year. Just one of many measures of equity. When you look at other consequences, healthcare spending just continues to go up and up and up, and it does come at a cost. And I would say for this group, notice the green line, cost to other sectors and other sources and places in which we might invest our income and our GDP. If you go back to the most recent landmark health reform, probably the greatest one preceding that was in the 1960s, where you birthed Social Security, Medicare, Medicaid, Community Health Center Network, and many others. It probably started with, it wasn't fully explained by the ACA, the Affordable Care Act or Obamacare, but you know, it kicked off, it was to be run by a senator at that time from South Dakota, and this is not something that hadn't been said by many before, but I think what Tom did in his book was point out that we have an inverted pyramid in care spending where we invest principally not at the foundational level, but at the end level or well downstream of the problem. We tend to work our way backwards rather than forwards. And again, some of this stems from Flexner, some of this stems from the way that we built our hospitals and systems, but you can imagine the consequences here is we spend an awful lot on end-of-life care, on folks who are already sick, and not as much on preventing the problems or at least mitigating or ameliorating them along the way. And yet, if you look at even as recently, a few years after USU was birthed, is 1978, you had a multinational, actually all of the countries of the world signed on to this convention in Almaty, and they had a 40-year follow-up a few years ago in Astana in Kazakhstan called the Declaration of Almaty, where they said, again, nations of the world agreed. If you look at primary care, which we've already showed you in the ecology, is the widest, most evenly distributed delivery, agent in our delivery system environment. Primary care is defined this way. It's essential health care. It's based on practical, scientifically sound, socially acceptable methods and technology that should be made universally accessible to individuals and families. We're starting to see those boxes again, individual within family, within community. It involves them. It's participatory. It's at a cost that the community and the country can afford, and it's the central function. This was probably the most famous statement from Almaty. The nations of the world said primary care should be the central function for an effective health system. And they were very clear at the 10th, the 20th, the 30th, and most recently the 40th anniversary. This is not basic healthcare. This is not, let's just have an entryway, take care of only basic things, and everything else trickles up into secondary, tertiary hospital environments. This is essential care. This is supposed to be doing most things for most people. And in the IOM report in 1996, they basically repeated these principles. This is the report of 25 years ago I alluded to. The logical foundation of an effective healthcare system essential to achieving its objectives. And what happened after these reports? Well, I'll tell you, after Almaty in 1979, the powers that be in medical establishment came back with a new report from the Rockefeller Foundation. And they said, that's all well and good. But at the end of the day, that horizontal vision, community-based, broadly accessible, it doesn't work. We need to break down things into boxes. Most of medical care has been broken into boxes since Flexner's days. We need to create organ system-based, disease system-based ways of organizing care. After Almaty, the group in '79 said, we need maternal child care, we need to focus on vaccinations, we need a couple of other key elements, and that's where we'll invest our energies. And you can imagine when you begin to silo and fragment, you lose all the cross-cutting virtues of both generalism and primary care. And so the reason that you have a new report and a consensus study labeled Implementing High Quality Primary Care is the group says again and again and again, and these aren't the only two reports, and Almaty's not the only declaration, we keep defining primary care, saying we want to get to, saying it's a health system virtue, we just can't seem to achieve it in our policy and payment and delivery environment. So this new report lays out, if you get a chance to read it, not only the barriers, but policy pathways to achieving it. I think it's worth a pause. If I were sitting in your shoes and I were living in childhood and in current training, primary care as I know it, a pause to say, well, wait a minute, that's not the primary care that I know, which does perpetually get boiled down to the basic, to the referralologist, to the person who is taught, can't do this or that or the other thing, because you need this many numbers and this much credentialing and these qualifications to deliver what you're talking about here. And oh, we don't work with communities, families, populations. We work in a box, probably called a clinic, in the UK a surgery, in these 15-minute encounters, trying to make sure that something efficiently comes in the door and out the door with at least a couple of questions answered, refer the rest, and don't worry about it. I just painted a picture that's a nightmare for anyone who's practicing family medicine. That's not what we do, but that's kind of the foil definition of what I'm presenting here. So I want to back up to, again, a legend up the street from Johns Hopkins, really in one of the largest and most specialized training systems around, Barbara Starfield, who over 25 years, and a lot of studies said, no, not in best practice is that the way of the world. Actually, if you look at primary care well delivered, high concentration, best possible practices, and you compare it to alternate models, you see better access, better equity. You see broader, again, delivery. You see delivery that's more acceptable to communities. And over 25 years, she wrote probably 38 to 40 individual scientific studies showing primary care centrality equates to all the kind of the outcomes we want. And she said, functionally, you can boil down core functions to 4. High functioning primary care, again, according to Barbara Starfield, really is about making sure that primary care is the source of first contact. That doesn't mean can't see non-primary care, but it means ideally patients have a usual source of care and a personal connection. Doesn't have to be a physician, but a personal connection. First point of contact that's trusted, again, when issues arise, to help to manage those issues, has a continual relationship, so continuity is built into that, provides comprehensive care, which she says is probably the most important element. Most things from most of the persons and the populations that this enterprise called primary care would cover, most things go through primary care. And you're really not sending, as we do today, a majority of the care outside of that office. And finally, it's coordinated. It doesn't work if primary care is somehow disengaged or detached from the hospital, the specialist. The best systems are going to have a way, and in an age of digital technology, you can imagine how much easier that should be to coordinate the care, to understand what's happening throughout a patient's care continuum. I think the things that I've, over time, imagined a little bit inherent to, but also importantly not stated by Starfield, and again, probably need to be done so explicitly. Primary care is complex. Done well, this is not basic. When I walk out of a clinic room, as I did yesterday, I can't remember the last time I didn't have 5 to 7 diagnoses listed. And they could range from the thing that the patient said that they came in for, be it acute, preventive, or chronic, the 5 other things that suddenly came up either in by the ways or, oh, I meant to mentions, and then the things that the patient didn't even walk in the room imagining we should be talking about. It's complex, and if you look at the visit, it's not something you can boil down to one problem and shuttle them out the door and say someone else will take care of the rest. It is about trying to incorporate most of those problems. We were doing studies of visits. These are slides you don't need to really read much, but you can imagine just from a visit ecology, the difference in primary care and any one of the specialty E&M services is profound. You really can't do what we're being asked to do in the current 10 to 15 minute clinical encounter environment. One of the reasons you're seeing a lot of burnout in primary care, but also in new payment models, a lot of moves to smaller panels, different ways of managing them, figuring out how to separate synchronous from asynchronous care. How do we get teams to take care of folks when they need the care, whether it's via phone, email, telemedicine, or in person? And in the most liberated systems with community health workers as part of your bridge, care navigators, and other forms of partners that are helping to make this happen. Also, again, underappreciated even in a health system where 70% and rising of our physician grads are going into subspecialties. Primary care is a specialty, but you would look at the rest of the non-primary care world as frequently subspecialized. Most of the care for most of the common chronic diseases, and this is, we actually did one on the ARC 14 chronic conditions, the other on the CMS or Medicare 15 highest cost chronic conditions. Most of the care, all you need to appreciate is on the right. It's in primary care, not in subspecialty care. So most outpatient touches for most patients with most expensive conditions is happening in the primary care setting. And yet, well, I'm sorry, and one more point, comprehensiveness actually has a consequence, and a good one if you're a health system or a policymaker or a payer. If you do more, and we've counted this in about 9 different ways now, you measure comprehensiveness, and it can be measured, you're going to see the kind of outcomes you want coming from greater breadth and depth, less hospitalizations, lower cost. We were just having a conversation. That does not mean that losing your obstetrical privileges, your hospital privileges, mean you're no longer comprehensive. You can define comprehensiveness by services, by settings. I work in the geriatric setting, in a nursing home, also in the office, also in the community, and by depth. We have a measure now called treat or refer. To what degree are the things coming through your door staying in your care versus going out for referrals and other testing? And by any of those, we're finding that you associate comprehensiveness with lower costs for your hospitalizations. Whoops, back to continuity. Sorry, continuity, also measurable. The degree to which you retain relationships, higher continuity that is, relative to lower, has profound effects on cost, hospitalizations, and a lot of other outcomes. Doesn't mean in all settings. The wealthy, healthy probably don't need continuity quite as much as the more infirm, more comorbid, more vulnerable, and you don't necessarily know that you're going to become those things all the time. So continuity is probably a virtue even when you are healthy, younger, that pays dividends downstream. And we capture these really poorly right now. So even getting to a system where, and that's something that our center has been working on, where we can actually measure using claims and electronic health records and all the data that we have in our environment, getting that back to payers so that they're valuing different things. Right now, you're predominantly working in a fee-for-service environment. In military medicine, it is different, but in the non-military community, for those not 9 million in the military medicine system, the majority of payment is fees for service. You do a service, you get paid. The incentive is more volume, more efficiency, do less other things, focus on the services, you get paid. The movement's toward value-based payment. Now you get paid if you meet certain metrics. Biggest problem in some of those metrics, they still don't incentivize the right things. They may help to get more preventive services included. Sure, it's important that I have a hemoglobin A1C on my diabetic patient at a certain frequency. They really don't get to health and to function. And if you want to say primary care needs to move back to the center of a health system, you got to measure its function. You're starting to see, as a result of years of volume incentive, declining comprehensiveness. It's in who we're caring for, family physicians caring for children, smaller and smaller. Doing obstetrics, smaller and smaller. It also is happening, oopsie, let's see here. Well, I think I hit a slide. It's happening not only in the services, but also in the depth. We do have strong incentives to refer more and refer more and to coordinate less. And so as you start to look at the workforce, you know, there's been a question over and over again in 25 years of policy reports on workforce. How do we get to more primary care? We need more, we need more, we need more. And in our reports, we've come back and said, you're probably right. It's not tenable to keep reducing the generalist core of your workforce. And that's not just primary care physicians. That's general surgeons, general psychiatrists, generalists in general. You start losing physicians specifically as soon as you leave urban areas. You don't find, really, other than FPs, nurse practitioners, and PAs, much in the way of primary care contact once you get outside of major metropolitan areas. But you could also say, you know what, we've got more primary care workforce than we've ever had. 294,000 when we measured it in 2010, probably in the 320, 330 range now. And if you look at trends, specialists, all physicians, primary care, everything's rising. Of course, you can see that the bottom line, primary care, is rising at a very low slope. But you could also turn around and say it's the worst of times. If you looked at the effects of expanding health insurance under the ACA, an aging, more obese, more comorbid population, you're going to have more use, more needs, and you're not keeping up. So we put out a paper that said, well, you may, if you assume certain straight lines of need and increasing insurance, need 52,000 new physicians by 2025. And really, it's even more subtle than that. It's based on a lot of assumptions for the status quo, but when I look at that care of children issue, I'll just tell you, when I start looking at the red and I start looking at the orange, that you can barely see on the left-hand side of the screen, but hopefully see in a mosaic or quick-like pattern. Those are counties that have few to zero providers that we can find or clinicians that we can find caring for children. This is a major problem for rural America. Big maps like this don't show you how even in big urban environments, you may be surrounded by physicians and still not have care. When I worked in Baltimore, opening a community health center, I was between Johns Hopkins and Johns Hopkins Bayview, two massive campuses. I could not get the vast majority of my patients cared for by any specialist, mostly driven by payment and insurance barriers. I was a forced comprehensivist because I couldn't get specialty access. This remains a big problem, so making more is not the only solution. You have a distribution issue, you have a composition issue, the workforce doesn't look like and resemble in many ways the population, and you also have a scope issue. If you've condensed what primary care is functionally doing, and a big gap exists between primary care training and primary care delivery, you have another, again, a bigger issue than just supply. And of course, when you look at from anything from current student debt to gaps in payment over a lifetime, there are huge disincentives to enter primary care. And you see it reflected in student interest. And fascinating, in every study we've shown, at the end of the day, folks come into medicine, myself included, yourselves included, with hopefully all the right values, virtues of altruism, but we remain economic agents. You can't ask a profession and a group of professionals to completely sacrifice something that's pretty inherent to human behavior in a free market, in a capitalist society. So as you get wider and wider gaps, as we showed over 25 years, you get less and less primary care and less generalism. That's for your PAs, that's for your NPs, that's for your physicians. Less general surgeons, less general psychiatrists, also some other things. Pediatric subspecialties also suffer this gap. And it's very easy to show, we worked with multiple economists, that it is a clear curve in relationship, no matter the altruism, no matter how much the student protoplasm want to work in these spaces, until you fix that problem, paired with the burnout problem, paired with some of the, again, role within health system problems, you're not going to be able to change these numbers. It shows up in allopathic and in osteopathic education. If you see in these curves, two lines, you can see that the osteopaths have produced a lot more primary care historically, and obviously have over doubled their capacity in the last 15 years, but they follow the same curves. And as you saw primary care decline in the early 2000s, it did it for the graduates in both systems. I understand from talking to friends and new colleagues in USU, it's the same kind of phenomenon we face here. And so you can imagine that there's another problem. We don't measure things enough. We don't capture good data. We started building out a social accountability portfolio in medical education about 15 years ago. What were we, again, combating? Well, we work in a different environment in the US than most countries. In the UK, you have a bucket of money that's sent to 16 regions. They determine what they need in terms of workforce outputs, and there's a set number of positions for certain types of nurses, doctors, et cetera. There's not 100% free choice. You can't come in and say, I want to be this, and expect that there will be a position in that space if you come out. You can compete for the ones that are there, but that's the nature of the beast. In the US, it's a little bit different, and you see it reflected in outcomes. And we were the first to start showing, you can really map grads and start to understand, if you're a stakeholder, who produces the things that you might or might not want. It's excellent at the Case Western. I did tropical medicine training there. Produces specialists, if you follow the red patterns, that land in counties, typically urban areas and large academic health centers. That part of the health system is well covered, and Case does an excellent job of it. But if you are, as the Ohio State Board of Regents were, contracting us to do a study of who remains in state and in primary care, which is a new mandate, you might go to a far lesser known southeastern Athens, Ohio university called Ohio University, an osteopathic institution. If you look at its clusters of trainees, pretty obvious. 54% remain in state and a near majority in primary care. If you're looking at investment, this one strangely is mostly privately funded and off of tuition. Case Western gets a huge amount of public funding. I think we try to say through a series of messages, if you invest a lot of public dollars in something, does the public not have a right to see the kind of outcomes that they want from the training programs? If you look at USU, and we've birthed something, if you're curious, called a med school mapper. It's had a recent revisitation, reiteration. You can go in and start to see where grads are landing. You can even roll over every one of these counties and see which med schools they depend on. You can start to see what percentages are remaining in states of training. It's actually not that important at USUS as it is for some states. And you can even start to see who's staying in rural areas, who's staying in health professional shortage areas. This kind of metrics and measure-based thinking for education is absent in the post-Flexnerian age and is really what we'd imagine as going beyond Flexner in the next step. Just for curiosity, this, anyone who's curious, this is the percentage of grads from Maryland in the Uniformed Services Academy who are working in low-income areas, in family medicine, general surgery, primary care, shortage areas, and rural areas. I didn't put it up to make any particular comment on the numbers, but to say this is measurable. This is something that can be tied back to investment. As we talked about this morning, if I'm talking to congressional stakeholders, I would start to talk about USU's impact on leadership, not just on military medicine, but on the broader community that the military is charged to serve. The 9 million lives are first priority. I look at the 325 million lives that are covered and very well served by USU's grads. You go to the next stage, which is graduate medical education. It's also easy to measure what happens to those outputs. In case you didn't know, we're up to about $18 billion in public financing of graduate medical education currently in the US, higher than any country per capita in the world. And for that, we get about a 25% reduction of primary care, even though every federal report on primary care said it should be 40 to 50%. We get about 5% rural production, even though by any measure of rural, you're still 15 to 20% rural. You don't get production of anyone going into the safety net or in rural health clinics from a number of institutions. And again, you've got to start imagining, what do I want for my public dollars invested of many sorts? You get huge outcome variation. And you tend to find when you're ranking, again, metrics like primary care, some really reputable, amazing institutions do some amazing things, but primary care is probably not one of them. So if you're going to be looking at how to invest public dollars in getting primary care, these may not be the places to look. On the other hand, you may find an institution like John Peter Smith, Community Hospital in Dallas, profound service to West Texas of people doing obstetrics, inpatient service, and far, far more. Decentralized training, just as a general principle, does tend to work. We're easily able to show that if you look at migration after residency, about 60%, 56% of grads stay within 100 miles of training. We're able to, quickly show, before I move on to this one, that if you invest in a community-based, community-partnered training model, you get even higher percentages. People tend to really stay and invest in those training sites. We're also, I hope, able to make it very clear now that primary care is no longer an individual doctor's sport. It really hasn't been in a long time. It's a team sport. This was just a survey of who's working with various types and members of the team. I can tell you, I cannot achieve. I'm only a day-a-week clinician now. I should have confessed that. I was a rural health scholar in North Carolina, intending to do OB, inpatient, and every procedure imaginable in rural North Carolina. And like so many, I married a physician. It's a little harder, and particularly a subspecialty physician. You need to be in an urban area. But even if I were there, I can't get the things that I need to get done to achieve Starfield's vision for primary care alone. I've got to have down the hall behavioral health. I need my phlebotomists. I need my allied health professions. I work actually in a residency clinic now where PT's embedded, behavioral health's embedded. I've got geriatric and sports medicine, subspecialized family physicians who still are generalists, but really help to expand what we can do. And we've even hired a cardiologist and a rheumatologist to come spend a day a week hanging out with us because we have a very different consulting relationship than we do. I think, and I'm not tracking my time very well, I'm probably just about out. Oh, I'll try to move fast. I think the only other things I wanted to make sure to include, really high functioning primary care doesn't stop at the end of the clinic hallway. You go back to Rudy Verchow, who most medical students, myself included, learned principally about for his thoughts on how coagulation and coagulation disorders happen. It's also probably the father of social medicine who really said, you know what, if medicine's going to succeed, it has to intervene in political and social life. It's got to point out the hindrances that impede social functioning, because at the end of the day, if we're going to achieve health, this is part of the business. These are legends in two spaces, one in South Africa, one in the United States, who really birthed a model called community-oriented primary care. You may actually hear about Geiger and Gibson because the George Washington University program has a whole institute dedicated to their work, taking Sydney and Emily Clark's work from South Africa and characterizing the COPC process and bringing it to the United States. And what they really said, as the Clarks found, when in a immediately pre-apartheid world, they found themselves asked to care for a homeland-based, Kolela, which was in a tribal homeland, which meant a sequestered area for Black South Africans, and asked to care for them with almost no resources, that was impossible inside the clinic. So they worked to define and characterize the community, identify their problems, develop interventions, monitor those impacts with involvement of the community at every step, and quickly found that more of their work was outside the clinic than inside the clinic. And this is really where flipping the way we approach healthcare delivery from a purely healthcare paradigm into something that's community-based is critical, and primary care is probably best suited to serve that function. You look at other reports that really help shape some of this type of thinking. I would particularly point out the 1967 Folsom Report. And what Folsom did in bringing a lot of leaders together from all walks of life. Actually, Miriam Folsom was a CFO, I believe, of Eastman Kodak at that time. So big business and others got together and wrote a report that said, you know what, not only does the generalist play a critical role in the health system, but that generalist has to understand data and information, and that problems don't show up along political boundaries. So if you're just counting on the county to care for this, or the city to care for that, or the state to care for the other, you're missing your call. You've got to understand how to build communities of solution. They cross these boundaries. He pointed out air pollution, water control. I think in this day and age, one can imagine suicide clusters. That was a community of solution we were working on at my kids' high school when 7 suicides happened in 3.5 years. One can imagine all sorts of equity issues. One can imagine that care for any of the chronic diseases you really want to stamp out, and the ability to take on life expectancy differences, they take teams, and physicians and primary care physicians play a particular role in achieving communities of solution. I think in, again, the military environment, it's become very clear that the VA is struggling with silos. Amazing system, but has been struggling with silos and is trying to figure out how to create these communities of solution. I think it does require thinking that's not part of your current training. If I ask you, who do you care for? Most likely you describe a patient or a group of patients. But at least when we surveyed family physicians, we found only about 1/3 of them could say, this is my panel by size or dimensions. I didn't even make a guesstimate. 2/3 said can't even guess. Could enumerate how many folks they take care of. Even less could say, this is my service area. This is the community that I serve. Now, they would tell you intuitively, well, it's generally here. But then we, in 2 or 3 studies, said, we'll draw it on the map. And then we would render their service area using their data from claims, and they'd say, holy cow, I had no idea. And there were really important pockets in what was missed and what was included. And understanding the difference between Ms. Smith and Ms. Jones, 2 diabetics, 40 years old with the same demographic profiles, one of whom has a very different ecology than the other one, very different resources, is a huge part of shaping their behaviors in care. We imagine a world where primary care in a big data age has access to community vital signs. You get blood pressure, you get height, weight, you get respiratory rate. But what about the poverty level, the, again, educational environment, the food resources that are actually available to your patients? Why aren't those popping up on your screen? And the screen's only one part, that's the room. Back to that limited box. What about panel management? What about that member of your team that's helping you, so you can focus on what's in the room in front of you? Figure out who that 5 to 10% of your panel and your population is driving most of the costs, using most of the care, and suffering bad health. And then who's not coming in your door? Community vital signs can be useful in helping a clinic really become an agent of community care. And this is all possible. I could spend an hour talking through all the things we've been building. We built a prime registry. Most primary care clinicians don't operate using registries. That's simple panel management. Who are my diabetics? How are they doing generally? Who's vaccinated? Who's not? Most of them also don't understand the service area. And I don't say that's a fault of the generalists. That's a fault of the system, and frankly, a fault of the training environment. And the data systems clearly exist to allow you to assess population health. We have, again, registries paired with population data in a FATE environment that allow you to go in and hotspot. What social determinants light up certain areas that impact my patients? Which parts of my patients light up with cost or utilization problems? In North Carolina, 10 years ago, before a big shift in payment policy, we had a system where all 14 divisions of the state Medicaid providers had detailers coming into their office and saying, hey, did you know, here are the high density tobacco users in your area or county. By the way, out of the 15 practices in this county, here are the ones who are adhering to National Heart, Lung, Blood Institute guidelines for asthma COPD care. Here are the ones who had the most patients in the ER last month. Here are the ones who actually follow medication guidelines and don't have polypharmacy problems. But more importantly, instead of just criticizing, here's some solutions. Here's some way to make those better. I would proffer, in wrapping up, that we've probably moved beyond 4 Cs. I just had a paper that I'd put out, and this is just Andrew's musings, worth everything you're paying for them, which is nothing. But I would say you probably moved on to 7 Cs. So yes, first contact, continuous, comprehensive, and coordinated. But we clearly live in a patient-centered age. Primary care has to be building all of its care around shared decision-making and understanding the patient in their environment. Has to have engagement with the community and those populations. And we have to inherently understand complexity science and multimorbidity in ways that we just don't teach and train. We still teach and train in diseases and organ systems. And that those 4 Cs going to 7 Cs also involve some enablers. If we don't learn to train in teams better, I think the military system does a better job of this than most of the communities that I know, but still has a long way to go. And integrate all of these elements into the same training environment, we're not going to see it on the delivery side. If we don't really enable use of tools to further primary care and generalism, you can't get the comprehensiveness. We're investing heavily at the ABFM now in AI and ML, not because we think, like so many technologies, that it's you know, a panacea. Most technologies, my EHR included, frustrate me more than help me. But boy, do they have the potential to do something different. AI and ML in the hands of a generalist is a weapon, and it's a weapon that reduces referrals and enhances competence and confidence and teaches us about panels and populations that we serve. We have point-of-care ultrasound, biometrics, tools that extend our power to do things that we have referred previously. We have to harness this in primary care better. We have to be teaching which apps are good to use and which ones aren't good, and how we become proficient in a different form of synchronous and asynchronous care. We've got to learn about social determinants. Again, we can't change all social determinants, and the healthcare system is the wrong place to do that. But if we can't speak the language and understand the right kinds of approaches and COPC, we're not going to get to tailored approaches to patients and populations. And really, it starts with modeling in the built environment. If you don't build your training environment to look like what you want, you definitely will be 30 years behind in getting there. You take your 7 Cs, your 4 Ts. We have a measurement culture that's growing. We're using competencies and milestones to measure our education. And again, recognize imprinting. We did a study that showed the way that you train affects your cost behaviors for at least 14 years. If you train in a really high resource environment, you're likely to spend a lot more on your care and do a lot more things when you get out. One of the things I love about the military training environment, it's a fixed resource environment, and stewardship is embedded in the way that you are trained and you practice from day one. And only with imprinted behaviors being recognized in training and modeled will we get to, again, outcomes like optimal patient experience, population health, lower cost, provider wellness, and I'd now say we've really moved on to a quadruple aim. We'd add equity into our outcomes equation. You face a lot of interesting questions coming out if you choose primary care. What's the right length of training? 30% of residency directors apparently say, yes, family medicine should probably be moving towards a 4-year specialty, not 3. Canadians say 2's fine. That's a debate. That's not an answer. I've just joined a National Academy study, funded in part by the VA, looking at whole health, which is really boiling down to how do you approach whole people with complementary alternative medicine, integrated behavioral health, and other elements, and not just do traditional care. How do you train leaders that can produce these communities of solution? And I won't claim to have any answer to the last one, but boy, am I tracking as your military health system and your VA health system slowly decentralize delivery, move more of it out of a closed and more into a shared form of care. Boy, does this have huge training implications as well as delivery system. I just say we would welcome you if anyone wants to come down and work with us once again, and I hope I've left at least 10 minutes for any kind of questions, comments, or thoughts, and I'll stop there.
Well, and yeah, don't go anywhere quite yet, but I wanted to say I'm Colonel Kuda, for those of you who I haven't met, one of the reservist faculty here in the Department of Family Medicine, representing Colonel Wynn, the department chair, and just wanting to say a big thank you for joining us, Dr. Bazemore. In the military, we have gifts that we give in the form of coins. And so hopefully this isn't the first one that you've received in all of the times that you've worked with military folks, but
Fabulous. I'll put it with my Marine Corps marathons coins and a few others.
perfect,
Yeah.
perfect. We'll get you like one of those shelves so you can organize all your coins. But we would definitely invite any questions. I will run up and down the stairs to you all who have questions. And I can always ask Dr. Bazemore more questions to get things started. So and Dr. Goss is watching the virtual environment too.
Good afternoon, sir. Ensign Phelps. How do you think that we can start incentivizing more medical school graduates to go into family medicine and incentivizing insurance companies to really push people to utilize primary care resources more than specialist care?
So, again, you saw my Dickensian reference earlier. These are best of times, worst of times moments. If I took a really cynical view, I would tell you, you can't. But I don't believe that. And I'd say you can't because I'm watching trends and so many seem to be going in the wrong direction. And I talk to too many students who say, my debt's mounting, the pressures on me, both at home and by the health system, are leading me away from family medicine. And to pivot that to the best of times, all I can say is it's a good thing that we're moving from fee-for-service to something value-based. It's not a good thing, but it's a consequential thing that you can't keep expanding your GDP spending. We are moving towards more resource stewardship, not necessarily because we want to. Healthcare is to some degree wealthcare, but there are finite limits to what we can invest in our healthcare system. And generalists, I won't specifically just say family physicians, but generalists, of which family physicians represent, one of probably the last largest bastion in physicianry, are going to be forced, called upon even more, I believe, in the future because of those two factors. You do have to, and you'll see in that high-performing primary care report all sorts of commentary around PC spend or primary care investment. We could document 5 or 6 years ago that if you measured health system investment in primary care, you can boil it down to a nickel to 7 cents on the dollar. Rhode Island, followed by Oregon, and now Delaware, with 22 states with bills on the table, are putting in investment legislation. So are some private consumers saying you have to put more money in this space. You have to have payers recognize that investing more in primary care, right? It may be part of a zero-sum health system game, but it's actually a good thing if you spend more on primary care or overall health system costs. As you rise your investment, you actually see overall investment drop. You do have folks live longer. People cynically say, well, primary care helps with longevity, right? And less morbidity, mortality, that's going to cost more eventually. True. You'd have to say, well, that's probably a good thing, but helping to connect the dots on overall health system investment in primary care leading to the kind of returns we want, absolutely critical. We talked earlier, we're not getting to a single payer system anytime soon. It's interesting that in this environment, you have a single payer and a closed system. There are tremendous inefficiencies with multi-payers, but within a multi-payer environment, you do have competition. You do have payers that show off what can happen when they invest in primary care. Look at some of the closed systems in these days where payer and delivery agent have been merged. What are the payer systems investing in? Well, you create Optum if you're United. You go and buy CareMore if you are Anthem. You increasingly are investing in models that are not hospital and ER centric. And you also start building your own as educational institutions. Should talk to, anyway, Chris Castle, a dean out at the new Kaiser Permanente training center, basically the new med school that's Kaiser Permanente, would say, oh yeah, we're doing this entirely differently. And it's purely selfish. Kaiser Permanente knows we need more folks who buy into our model, our culture, which breeds better health at lower cost. So we're just going to go train it ourselves. And I think as payers like that starts to illustrate, this is the pathway in training to get what we want out on the receiving end, you'll get closer. Finally, I mentioned social accountability. We put out these measures 15 years ago. We ran into major headwinds from some understandable stakeholders well invested in the post-Flexnerian or in the Flexnerian model of healthcare delivery. We just this year finally cracked the nut with Bob Morse down at US News. They are putting, at least in their primary care rankings, percentage primary care outputs, percentage rural, percentage of graduates working in health professional shortage areas. And then they carved it out, but they did bite on our percentage underrepresented minorities as a proportion of state underrepresented minority populations as another different way of measuring what schools produce. Deans are highly motivated by rankings. I don't blame them. There's nothing wrong with deans following the metrics that guide their job. But we need to set up the metrics a little differently. I pointed out a few of these. We need more transparency in the social accountability measurement space. And there's a lot of work going on there. And then finally, if you move to value-based payment and people take care of whole populations with a fixed budget, you've got to set up primary care teams. If you train the right type of primary care, it happens here. I tell you, I look around the room and I see more leaders coming out of military training programs in the family medicine environment proportionally in about any other form of training I see. If you do include leadership, you will get family physicians to the C-suite. That will change the training and the purchasing environment in the future.
Great question. I know we have a second year small group that you all have to go to, right? So definitely want to,
Thanks, guys.
Thanks for attending. Any faculty with questions that you want to pose? Oh, yep. And anyone online? Wow, we definitely had a lot of second years here with us. Oh, Jules.
Lieutenant Commander Seals, sir, I'm one of the new faculty here, young faculty. It may be too early to tell, but do you think COVID has changed the environment of primary care in relation to the just physician population?
Absolutely. So I had the pleasure of working with the editors at both Annals of Family Medicine and, because of my position at the board and some past relationships with the JABFM, the Journal of the American Board, really putting out special issues in a little different format than you would usually go through. The peer review process was rapid. It was published first and asked questions later. There's too much information that is needed and circulating in pandemic to hesitate. And I say that because it was amazing what came out on these special issues. And I'm going to point out the positive, and then I'll get a little cynical then and maybe return to the positive. But the positive, okay, my colleague, the chair at OHSU and good friend Jen DeVoe, she instantly was turned to by their dean at Oregon Health Sciences, asked to help with a statewide implementation strategy because family physicians and primary care tend to already have integration of public health and population health planning embedded, and Jen had the statewide department. Town gown divide easily bridged by family medicine. They converted 2 of their offices into mini ICUs and step downs. They got called back into hospital space, even if they hadn't been training in a while, because you had a massive deficit of providers, of clinicians. And they were being pulled into county health department discussions, early vaccine distribution discussions in so many ways. These are the bright spots. I can tell you about the negative spots in a moment. It shines a light on the power of generalism. In a time of crisis, boy, do we need it more than ever. I say the downside came in, we did an international study and looking at the consequences of low investment in both public health and primary care and how ill prepared we were. You know, everyone loves the Bill Gates video. We saw this coming. You could go back to Nostradamus and talk about predictions of plague. It hasn't changed again and again and again, this recurring cycle of getting woken up by pandemic to the inattention to health and health systems that promote health and public health primary care being right there. So, you know, I remember rereading the 2012 Public Health Primary Care Integration Report from the National Academies and quoting it often in early in pandemic, and you're just looking at strategies and going, why can't we get here? So the cynic in me says the pandemic will fade. It has reawakened an awareness of the need for greater public health primary care infrastructure, technology. I don't care if it's your vaccine registry, your coordinating principles, your plan and strategy. The cynic in me says, but that will fade. But then the positive side again is what I just said earlier. I think pandemic becomes endemic and more are to come, and the population is aware of that. Underinvestment has real consequences. The equity conversation, pandemic conversations overlap, only doubles down on the need for primary care, public health investment. And so it just feels a little different. I don't want to say primary care overnight suddenly became sexy again. That would be the wrong term. But I do imagine, and this is where I, back to saying, well, we'll cycle out of this and things will return to normal. I don't know. I imagine over the next 10, 20 years, you're going to see consequences in the same way that the way that airports changed after 9/11, consequences of pandemic and equity conversations that show up in medical education, in training, and in the way we pay. They're happening all around us. So I'm optimistic.
Well, I'll toss out a question, sir. And I was going to save this one until the students were here so you wouldn't get a barrage of emails. But if folks were interested in getting back in touch with you to connect, what's your preferred, way of
We're all
connecting?
The last name at theabfm.org. I think we had to add the V. I've come to understand we had to add the V because someone already grabbed ABFM. But A. Bazemore at theabfm.org, and we welcome. We're right down the street. We were talking about Mark earlier. We had some students that would come down to the Graham Center and visit. We, post-pandemic, are not sure we're going to spend as much time in the office as we did pre-pandemic, but we've got a pretty good virtual system too. And while we're not a teaching institution, so we can't take an unlimited number of students, I just talked to my CEO this morning again on the way over here about the importance of being here today and just saying, I really don't understand and haven't understood well enough some of the numbers, the dimensions of military training in ways that we should. I used to meet with the head of the data unit for the 9 million lives covered, who was a friend and a college classmate, about having collaborative works. I would love it if there's a USUS to Graham Center, I can't speak for them anymore, or ABFM relationship. And we talked about numbers this morning. I see big pictures that you should and could carry into congressional conversations, executive conversations that show your genealogy, that show your network impact, not only on military delivery, but as you're seeing a shrinking budget and more movement into the community, it's a perfect time to say, well, let us tell you what this training environment means to the broader community that the military serves and its core purpose. My residency director, I work a day a week at VCU Fairfax Family Medicine, now Inova Fairfax. Sam Jones, military physician. He's been the chair of the ABFM, the chair of the AFMRD, the chair of the VAFP. There's a natural history of leadership training here that doesn't happen enough in a lot of other places, and it shows up all over the health system. So I'd love to do some tracking of that.
Thanks, sir.
It's not really a question, but we have virtually joining us Brigadier General Mary Krueger, and she wanted to know if we could share your slides with her or with the participants. I do have them, but I wanted to make sure that we could share.
That I've increasingly been taught over time that when I share an article that I wrote that showed up in someone else's journal, I don't own what I just shared, but I don't think there's anything too proprietary in that deck. So, sure.
Hi, I just had a quick question. This is Monica Lukendorf. I'm a maternal fetal medicine physician, currently the chair of the Department of Gynecologic Surgery and Obstetrics here at the Uniformed Services University. I really appreciated all of the maps that you showed, and I was curious if you had done any maps looking similar to what you showed for children, if there were any deficits in women's health or maternity care in the U.S.
We could follow up in long discussions, so I'll start with where I am now and then back up to the Graham Center. Two medical anthropologists on my research team in Lexington, both trained in reproductive and women's health studies as medical anthropologists. It is core to their heart, soul, and work, and we do a lot of work trying to understand, just on the family medicine side, what happens between training, and we do surveys, 67% response rate at graduation of intent to practice. You're walking out the door, you've already got your job, and you're answering a question. And we can still say a very high proportion of family physicians intend to have obstetrics included in their practice. And then we survey them 3 years later, plummet. And then we do the long-term survey, and it's down. It's 1-2% that are doing 25 plus deliveries a year. At the Graham Center, to your mapping question, helped to build a mapping enterprise, had colleagues both on the midwifery side and ABOG, ACOG. I don't know if you know Bill Rayburn, former chair of ACOG, and was the chair of the department out in New Mexico. He came and was a scholar at the Graham Center, and yes, we did papers on shared care of women's health that included some maps. Biggest problem we ran into in doing a comprehensive look at gaps was you could find we used the master file paired with CMS data to find the physicians. There's not a master file for nurse midwives or any alternate care providers, but you could at least say, here are the physician deficits, and they're pretty easy to spot. And it all depends on what you want to look at. Back to there's a difference between saying we are lacking physicians and and one that says we're lacking physicians who do this service. Family physicians are all over. There are a lot of midwives, but there are huge, particularly rural deficits here, and telemedicine is one of the solutions. Let's just pick on South Dakota, the 2 training institutions there. Setting up telesurgery, tele-ICU has huge enabling power for family physicians. I was sitting in a room watching someone run blood gases with peer South Dakota residents and faculty from the ICU to the not ICU that avoided a transfer. Huge money saved. You can keep, as an MFM specialist, I'm guessing what might go through your head as desires, but if you can keep all but the tip of the iceberg or the top of the pyramid, the sickest of the sick, at home, that's probably better for services, resource use, your sanity. And I think we have huge opportunities to enable MFM to family medicine midwife connections that maybe reverse the trend of deliveries all move to flexnarian academic health centers. I work in Honduras, by the way. That's our whole goal down there too. You really disrupt the social fabric and you create huge pediatric health issues when mom goes and lives the last 2 to 3 months in an urban environment and away from family and community. And it's not quite the same in the US, but you know, I think the power of MFM to family medicine connections is not even close to being tapped, and we have the technology to do it.
Also, some data that shows that the density of MFM providers kind of overlays with a lot of the maternal morbidity and mortality that we see. We don't have as many practitioners in the South portion of the country. And so kind of trying to correct that or develop a collaboration. I know there's a pretty effective telehealth for maternal fetal medicine in the state of Arkansas, because I think they've only got 1 center that practices. So they have an Angels network. And so I think that would be something great that we could help with.
Curtis came in when I was at the Graham Center and spoke multiple times on Angels and the Arkansas model. I think it's amazing. Another one to look at is what Mayhex is doing with the family medicine OB programs there in the 18 counties of Western North Carolina. Great team-based training, excellent teaching about triage. You know, you're hour and a half away, what needs to come when. If you can get protocols down, you can keep a lot of care where it should be, in the home, in the local clinic, local hospital, and only bring that which needs to be brought to Asheville. So.
Other questions? Just come down and.
Can I ask a question? So.
Oh, you have your.
I was just going to say to particularly the faculty here, what is, if it's not an indelicate question, what is the reaction to shifting a lot of the care that has been captured and closed into community settings? And what does it mean for the training environment? Okay, okay.
Well, I was going to say, I think I have significant concerns that the civilian community can provide all of the care that the military envisions happening.
I read the HSR article last month.
Yeah, and I practiced in San Diego prior to moving here, and so we would get referrals from Weed, which is far north in California, and we would get referrals from 29 Palms because their only civilian provider had quit the practice, and so patients were driving between 3 and 4 hours to come get MFM services in San Diego, because there really isn't a ton in between, and so if you're going to drive to Los Angeles, it's almost equidistant to San Diego. So I think if they start closing some of the subspecialties, they're going to realize that they're not going to be able to provide that care, or they're going to get a civilian provider who doesn't understand the military mission, and they're not necessarily going to get patients' recommendations that are going to be helpful for the commanders. And then I think they're also not understanding that the civilian setting doesn't have just open appointments sitting around waiting for people to show up. So I think there's going to be that. And then there's a significant concern, the graduate medical education perspective. We have all these new medical schools. We do a large part of the training. We've already started to see a lot of the Navy hospitals close, and likely some of the other Army hospitals and Air Force ones along the way that will continue to impact the GME mission.
And those are, as is so much of U.S. healthcare and training, those are divorced, GME, UME. So that's a consequence that I guess is not being fully factored into all the decision making.
Well, I agree with everything you just said. Lisa Harris, I'm one of the faculty here. I think the other concern is making sure we, as a military training facility, are able to maintain the diversity of patient care and the acuity of patient care needed to sustain education, appropriate education, for particularly for family medicine.
So I'm guessing that much of this is still to play out and be determined, and there's a lot of narrative yet to be written. Okay.
Hey, sir, Mike Arnold, I'm faculty as well. I think we're struggling right now just in trying to keep our residencies going. They're trying to take away a lot of the obstetricians, the pediatricians, and that has the option of some of our programs are actually struggling to meet their child numbers required by the ACGME for certification, which is such a tragedy. Interestingly, we found out that one program just moved a pediatrician up to the family medicine clinic, and we're able to jump their numbers up. So there's innovative solutions there, but the flux, I think, is really the worrisome part.
Well, and that's been such a struggle for so many programs. Our programs had the same. We, it's back to your innovative solutions. One of the reasons we engaged with a community health center, something I long hoped we would do. Community health centers, thanks to the WIC funding and, certain health centers' tendency to have more young, both women and children, that was the way. That quest for numbers led to a pretty interesting community partnership too. I didn't know if these were possible for military training programs, how much you can partner with some of the community sites. Okay. Interesting.
And if the
looking and relooking at new, so varies by GME program. However, many residencies are looking and relooking at new military-civilian partnerships to bridge the gaps.
That sounds very familiar. And yes, obviously this is confluent with the merger. And to your point, the desperate competition around training, basically training opportunities to do any number of procedures, care for certain populations, et cetera. It's a bit of a free-for-all. I don't know how the military budget would allow you to compete with what some of the private GME is having to pay for certain community experiences. And boy, you throw the osteopathic and the offshore UME into the mix, and they just set the price of poker on, way up to be able to place their trainees. And I'm sure that has effects on military UME. And to your point about actually caring for a diversity of populations in many different dimensions. Really hard to come out a comprehensivist. It's really hard to understand all the problems you'll face, not only in the military system, but in community systems if you don't have exposure in your training, that's for sure. I hope everyone's aware of the writing committee, the RSC's work right now. One of the reasons that the ABFM hosted what we called a Starfield Summit last November and published a special edition with 38 articles, that 7 C's figures was one of my contributions, is we are trying to inform, not influence, but inform that writing. And that balance between innovation and regulation is such a tension. You know, why 1650, why certain numbers ever existed is always going to be questioned. And exactly, are they fixed? Are they guidelines? You know, how do we get to threshold thinking? Okay, you really do need at least this many to have a chance at competence, but beyond that, it's competence and milestone based. You know, how do you get to threshold thinking? How do you get to creative thinking about asynchronous, synchronous care counting so that you incentivize real world training? Because I'm sorry, that's what we're all doing, you know? Can't say that's what'll come out on the other end, but that, you know, that whole summit was a dance around, please don't rewrite, make this more complex, and come out with something that looks even less like your question, what a post-pandemic, and frankly, it goes way back before that, high-performing primary care delivery system needs. And then the 4-year issue is, that's just a tiny one. Yeah, that's a big darn deal. I happen to have a CEO who's a really strong believer that longer is better, but boy, do we have folks who are passionate about the other direction and about the access consequences and all the problems and the funding consequences that come with that and the recruitment consequences. And there's a real tension there between, oh, wait a minute, but if you went to 4 and it was richer and it produced this uber generalist, would that be more appealing to the learner and more able to do all the things that you just talked about? Or would it just scare everyone off? And without a payment model that's hitched up to it, you would be the final death of family medicine. That's a rich debate.
Hi, Sarah, Lisa Harris again. The talk about the 4-year residency program for family medicine and the concerns about the cost that's associated with that has me thinking about programs. I think it was North Carolina that looked at a 3-year kind of medical school, and then you go into family medicine. And I just think if it's 3-year medical school, 4-year residency, it's 7 years either way. And if that's been tried, looked at, thought about.
That has about a 50-year history. And back to, so I'll give you a side note before I get to the 7-year model. I trained in the first family med psych program. MedPeds was birthed at Chapel Hill, where I went to medical school. We have tried these innovative hybrid models for years. The payment delivery system drives the training program. My FP Psych program produced some amazing training. I feel more comfortable in behavioral health care than I ever would have, and I didn't do the combined program. I just did family medicine in that environment. But what do all the grads of the combined program do? They become psychiatrists or family docs, because that is what the hole that this widget is asked to fill in our current payment environment produce. It's a little different issue with 7-year training programs. You saw it, the resurgence in 2006 started with Lubbock, Amarillo, the 4 cities that were served by, I believe, Texas Tech. And they went back to a 3-4 model. It actually works in West Texas. In Cincinnati, my classmates, 3 years running, included the valedictorian of the University of Cincinnati College of Medicine. They actually said, we're going to partner with one program, family medicine only. So the only way you could do a 3-4 was to go into family medicine. There's an innovative model. Again, we got the valedictorian 3 years running, pretty sharp cookies coming into family medicine. All 3 of whom said, I was considering it, I really thought about it, but I would not have done it if it hadn't been the pathway to efficiency, to what I really wanted to do in getting there faster. Why did that die? Deans changed. There was some concern over competence and training, and I think there was a dean's perspective. They didn't like that their valedictorian being pushed by US News rankings. They were told that one dean's clear incentives were, I'm going to get us from 42nd on the NIH funding list up to 25th, and I want to move up the US News rankings. That's not the pathway to getting there, making more family docs. So I think these have been tried. I think they can work. It's amazing how all these pieces that we've been talking about fit together. I don't think that the models of 3-4 have ever failed from a training sense. There's always a consequence. But keeping buy-in, keeping back to divorce GME, UME, keeping both sides of that coin happy. It's kind of like I helped to open what we called a teaching health center in Cincinnati before I left. Oh my gosh, we loved it. The community health center I worked with loved it. It died because there was no funding. And our resident training cost more than a low margin health center could afford. And then my chair finally said, we can't do this anymore. The health center hasn't paid us in 9 months. So without some kind of bridging funding, now called the THC GME model, those things don't last. That would require very high level investment that said 3-4 programs. Right? Go. Thank you. You've got a path. Yeah, I saw that. I like that. Well, be happy to. I don't know the history in Cincinnati, but I'd be happy to help you find it if that would help your cause. So. Okay.
So I have a follow-up question. You mentioned earlier the Canadian system, they do only 2 years of family medicine training. Can you talk about that?
Yeah, it's fascinating, isn't it? And one would generally say Canadian generalists are exceptionally well trained, well regarded, trusted. You don't see you'll see the articles coming into Toronto newspapers, et cetera, that complain over lines and queuing, but you don't really see much other than love between patients and GPs. I speak with cousins who live there as well. You have about 93% of Canadians can name an individual general practitioner usual source of care. In the US, it's about 18%. And so I start with the consequences first. Clearly, 2 years has not forced the Canadian system to suffer. You also had a big payment boost that made GP more attractive, and you reversed. We wrote a study in 2005, I believe, and a follow-up in around 11, 12, 13, between which was a natural experiment where you raised GP salary, and all of a sudden, instead of 1/17, they have 17 med schools. We wrote it up and said, one of your med schools is producing US physicians. The vector flow was south. You actually inverted the flow by the second study, and it was mostly because you were attracting folks to the Canadian GP environment. And they're close to 50% of their physicians are GPs. I don't know that I've ever seen comparative quality studies. Let's pit the Canadian GP against the US family physician against the Aussie GP. But I don't think I've ever heard anyone disparage that form of training. Don't hear me endorsing 2 years versus 4 versus 3, but I do think it's a pathway. And one thing that my Canadian colleagues regularly say is in a lifelong learning paradigm, it's not as though you're 2 years at the end of the road. What it really takes is your UME, your GME, and an excellent post-grad learning environment, and that a lot of Canadian GPs really embrace. 2 years is not enough to get all the training we need, and they, somewhat like the tracks that we see in our experimental programs here, they frequently engage in what we'd label postdoctoral kind of work. The Australian model is somewhat similar. Australia, UK, or the European model generally, you're coming out, your first step is kind of like our intern year. You're a hospitalist, you work in a hospital, and then you get into a 2-year apprenticeship. And then frequently, particularly if you're going academic, you might get what we would call a PhD. You get your postdoctoral, your research, or your specialized area of care. My Australian colleagues, one says, oh yeah, I'm known in the practice as the dermatologist. Did a lot of skin care, skin procedures, an extra year of training in that environment. Micro teams of generalist specialists. All right, I do all the derm, I take care of the sports med, I'm more of a geriatrician. That's the risk is always that you'll, in the wrong payment system, become specialist and lose your generalist nature, but that usually doesn't happen. I think it's one of the reasons that we also have a rich debate about CAQs in family medicine and whether we should add to CAQs and or elevate what those certificates mean. I happen to be profoundly against anything that would threaten primary certificate, at least for family medicine, being the way we're identified.
So Dr. Nguyen said we hosted a Canadian Surgeon General last week, family physician, and I told them if I was a Surgeon General for the day, I would change our MHS training to compare to theirs.
Okay, there we go. I think if you want to know where I think this debate lands, it's probably more experimentation. That's the US way. I would be surprised, at least in any next iteration, seeing the ABFM or the RRC ACGME move to mandatory increase in length of training. I wouldn't be surprised to see more room to flex. If there's a good thing about fragmented U.S. healthcare, it's that old 1,000 points of light idea. You have a lot of room for innovation in the U.S. healthcare system, and a lot of room for tailoring to local microenvironments. So you could see Kaiser run off one way, the military GME another way, and traditional East Coast program a third way. In 4-year training, the length of training pilots, they didn't produce similar outputs. OHSU, probably the original 4-year model, that absolutely included a pathway to an MPH, so it had another degree involved. Other 4-year spaces, it really is figuring out your niche, your track. In others, it is purely academic and leadership training. So I think you'll probably see some license to expand experimentation. I'd be interested to see what would happen if you included 2, 3, and 4. There's some brand recognition risk. I think that's one of the other arguments against the innovation side is what's a family physician is already hard enough to explain. We have a real trouble explaining who we are. How about we water it down further by, really opening up one form of training versus another and calling them all family medicine. So. Thank you.
Looks like we don't have any other questions. Any questions from the virtual world? Anybody before we end? Feel free to unmute and speak if you have a question. Okay, sorry. So Dr. Bazemore, Dr. Nguyen is saying thank you. Wonderful discussion. Thank you. Thank you, Dr. Bazemore.
Thank you. Thanks for giving me a good excuse to dive back in and see the campus and better understand.